Hello, welcome to this lecture, an introduction to individual-based models in epidemiology and to inform policy. The intent is that this lecture does not assume any prior knowledge of modelling. This is intended to be an accessible introduction to individual-based models in epidemiology and health policy. Clinical disease experts and health policymakers are encouraged to familiarize themselves with the concepts of such models. We need your input to make these models as relevant as possible. Now, health policies relate to how we organise our healthcare system or promote healthy lifestyle choices in order to generate health in our populations. Let's imagine our aim is to maximise overall quality and length of life in our population. Imagine we are considering a change in health policy. What would we want to know? I think we'd want to know whether the policy is likely to lead to an increase in overall quality and length of life in our population. So how do we go about finding out if the policy is likely to lead to an increase in overall quality and length of life in our population? Often a new policy will be to introduce a new intervention, such as a new drug to prevent or treat a disease, or a new test for diagnosing or predicting risk of a disease earlier. We need to consider the direct and indirect effects of the policy on the population. Now, often, the health effects of a proposed intervention are entirely positive. However, most healthcare systems have limited resources. Introduction of the intervention may well result in less resources for other existing healthcare. The policy decision is then about whether the result of the introduction of the intervention would be a net gain in health. Now, in addition to these resource use considerations, for some potential new interventions, the health benefits of the intervention may be potentially offset by negative health effects. For example, there can be adverse effects of drugs. In the case of drugs for infectious diseases, one such potential adverse effect is the fact that the policy to use the drug in a given way may result in increases in spread of drug-resistant infections. So how do we go about addressing these questions so that we can help to inform health policy? Often, the persons responsible for making policy may have to use their best judgment after consulting with various experts. A disadvantage of this approach is that the decision process is not transparent. Often, the decision can be far from straightforward and involve trade-offs between positive health effects, direct negative effects, and indirect negative effects due to resources being diverted. It's very difficult for a policymaker to appropriately balance all of these considerations. Another approach, though, is to try to represent the comparison of the policy options mathematically. This might be referred to as an analytic framework. Various approaches are used: decision analysis models, decision trees, Markov models, compartmental models, and also individual-based models. We focus in the rest of this presentation on individual-based models. Now, an individual-based model is designed to simulate the experiences of people in a population over time. Each time the model is run, it generates a simulated data set of variable values for a cohort of individuals representing the population of interest. So, for example, at one point in time, we would have this representation of the status of a population. So the rows represent different people in the population going up to 10,000, and the columns represent different variables: variable 1, variable 2, variable 3, and then a variable indicating whether the person is alive or dead. And then we'd use the model to simulate the status of the population 3 months later, or any time step can be used. So you'd have the same representation of the values of the variables 3 months later in each individual. So for example, if we had a simple model of cardiovascular disease, we would have the status of the population at a certain time on the left, and we might in each individual have their systolic blood pressure, a representation of their total cholesterol level, whether or not they're a cigarette smoker, and whether they're alive or dead. And then, as I say, one time step, let's say 3 months later, we would update those values for each individual using the model. And then the model would do this over multiple time steps, depending on for how long we want to simulate our population. So, for example, if we wanted to represent values of 100 variables on 10,000 individuals as they change every 3 months, from 2010 to 2024, this means that when we run the model, we would be generating up to 100 times 10,000 values per 3 months. And then 60 times that because of the number of periods from 2010 to 2024, giving 60 million variable values. Although it should be noted that we don't need to create a new variable value unless the value actually changes. Now, in some individual-based models, the experience of each individual is entirely independent of the other individuals. In other models, a person's health experience can depend on others. A common example of this, of course, is in modelling of infectious diseases. But there are also other examples, such as when a person's health choices, for example their diet, are influenced by others in their social network. So talking about modelling infection within a population. Here we represent the life years experienced by each individual with horizontal orange lines, and we've just got 7 people represented here, going over a number of years from 2018 to 2021. The yellow line within the orange line represents the fact that the person has an infection present, and the black line indicates the degree to which there is reduced quality of life or disability for the individual during that time. And the black square is when the person dies. Now we note that we consider the outcomes of a whole population of people, including those who could potentially be susceptible to infection, as well as those who are already have been infected. Now we model how infection is transmitted and newly acquired within the population by modelling the determinants of infectivity of infected people and susceptibility of uninfected people. These determinants depend on the infection. So for HIV, for example, it depends on condomless sex and the viral load of the infected partner. So you can now look at a simple model of an infection. If you follow that link there in the screen, you can see an example of an individual-based model of an infection. This is coded in Python. So you would need to press the arrow to run when you come to that website. You'll see a series of tables tracking the experiences of a cohort of 1,000 people over 100 days. And the columns show the day, the person ID, whether they're infected, the contacts, the others in the cohort with whom they had contact, infectious contacts, contacts who are infected or infectious, whether they have ever been infected, and the day of the infection if they ever were infected. Initially, only person 0 is infected. So look at the people who had contact with person 0, for example, and look at the next day for these people to see if they became infected. And the probability, as you'll see there, per infectious contact is 0.2 in this example. Now, at the bottom of the program, you will see that you can change the following to produce different epidemic patterns. the number of days to run, the population size, the initial number of infected people, the chance to become infected per infectious contact, the number of days to remain infected or infectious, and the number of contacts each day. So this is an example of an individual-based model in which there is an explicit network of contact patterns between individuals. An alternative approach is where the risk of acquiring an infection for a subject through a given contact is determined at random based on the concurrent prevalence of infectious contacts among contacts to whom the subject is potentially exposed. Now, an individual-based model is largely defined by the list of variables or attributes for each individual and the expressions that determine how each variable value is updated in each time step. It's important to note that the expressions which represent the development and progression of a disease are what we hypothesize to be true underlying causal effects. Now we show here examples of variables or attributes that we might have for each individual. I won't read them out. You will note though at the bottom I talk about DALYs incurred in the period, and we'll come on to talk about what those are. So thinking of the expressions that determine how a variable value is updated in each time step, let's think of some examples. First one might be presence of HIV in a model of sexual transmission of HIV. So let's say we're updating a variable indicating whether a person has HIV or not for a person who currently doesn't have HIV. So if the person has no condomless sex in this time step, we might indicate that there's zero risk of infection. And then if they have condomless sex with a new partner of HIV status unknown to the person, and with no other partner, then risk of infection might be specified to depend on these various things amongst others in the population having condomless sex with new partners. So the various things are the HIV prevalence, then the HIV viral load in those with HIV, noting that there is zero risk of transmission risk if the partner's viral load is undetectable, and whether the person is taking pre-exposure prophylaxis to prevent them from having HIV. We might also want this to depend on the number of times in the time period that they had condomless sex. So the next example is that we might have a variable which represents the person's systolic blood pressure. And the updated value might depend, for example, on their existing systolic blood pressure value, in their age, their gender, their body mass index, the level of exercise they have, their salt intake, and whether they're on an antihypertensive drug. It may, for example, be that these determine the probability of a 5 millimeters of mercury increase, and whether or not this increase occurs is then determined by sampling from a random distribution. Now, it's important to note that we are generating values for the true underlying systolic blood pressure, not the measured blood pressure. If we want to take into account the error in measurement of blood pressure, we can create a separate variable which represents the measured value at any point in time. So this will be the true value plus a randomly determined error. The same principle applies to any diagnostic test for any condition. We use our knowledge of the accuracy of the test to determine who is diagnosed and who is not diagnosed despite having the condition, and who is falsely diagnosed. So the accuracy of the test is specified in terms of its sensitivity and its specificity. Sensitivity is about how good the test is in picking up the disease in people who have it. The specificity is about how good the test is at avoiding mistakes and diagnosing people with the disease when they don't have it. So another variable we might have would be the occurrence of a myocardial infarction, a heart attack, and whether that occurs in a given time step for a person. So this might depend on their age, their gender, their current systolic blood pressure, their smoking status, their low-density lipoprotein cholesterol level, presence of diabetes or not, and pre-existing cardiovascular disease in the person. So these variables might determine the risk of an event, and whether the event actually occurs depends on a random draw of a number between 0 and 1, where there's an equal probability of each value, and that is called a uniform distribution. So continuing with this example, the occurrence of myocardial infarction, we might have an expression which looks like this. The risk of myocardial infarction in the next time step is given by a number P1 plus P2 times the age of the person plus P3 if they're male, etc. And then we might have a random number drawn at random from a specified distribution which is added. So P1 to P8, these values are examples of model parameters. Now in this example we are in fact more likely to have an expression on the logarithmic scale and then transform back to the linear scale. So let's come on to talk about model calibration. So calibration is the process of trying to ensure that the model reflects reality insofar as a model could be expected to do so. So this involves comparing model outputs from our simulations with actual real data. Since the model simulates changes in variable values for individuals and how they change over time, it is possible to compare model outputs with any source of data by mimicking the way the study collected the data in our simulations. So for example, a cross-sectional study can be mimicked in the simulated outputs and results compared with the actual study. Similarly for a cohort study where we follow individuals over time. So calibration might consist of running the model multiple times and each time sampling the value for each parameter from a distribution reflecting our uncertainty over that parameter value and possibly variability between settings in the value. Then we might compare the model outputs with data. We might exclude those model runs for which the calibration is judged to be inadequate because they do not appear to plausibly reflect reality in our setting of interest. The sets of parameter values that result in model outputs that look close to the data might be preserved for future runs of the model when evaluating policies. And this slide shows an example of modeled curves of HIV prevalence for multiple selected parameter sets. And you can see the black stars represent the actual data. So let's consider now dealing with uncertainty. Usually there will be uncertainty or variability between settings in appropriate parameter values used in expressions to update variable values over time. In this case, it is again helpful to choose a distribution of values for each parameter rather than a single fixed value. A value for each parameter is selected each time the model is run. It may be that some model runs produce outputs that are outside our acceptable ranges of calibration, and these can be discarded or ignored. By running the simulations of the model multiple times, looking at the answer to the policy question each time, this can allow conveying of uncertainty in the answer to the policy question. It can also allow analyses to study how each parameter influences the answer to the policy question. So now when calculating health outcomes resulting from implementation of a policy, how do we measure health? So one measure of the health in the population is simply the number of life years lived. And you can see this represented here with an orange horizontal line for each person with 7 people. And you can see the life years lived by those 7 people through the years 2015 to 2018. And then we can also take into account the quality of life of people while they're living. So these are quality adjusted life years. So now the orange line, we have parts of black in the lines at some certain points, which represents the quality of life represented by the orange part of the line. So you can see that individual 5, for example, has a reducing quality of life through 2016, 2017. Or we can turn this around completely and think about the years of life that are lost. Say, for example, if we expected a person could live up to age 90. So the black line now is while the person is dead, but would have been aged less than 90 had they been alive. So looking at the black lines, we can sum up the years of life lost. Now, with years of life lost, we can also extend this to the concept of disability adjusted life years. So again, we're counting the life years when a person is dead, but we're also counting the disability while they're alive. So including the black lines when people are alive. So how do we compare the effects of two possible health policies? So what we would do when we have our calibrated model would be we would run the model up to the time point at which the choice of policy arises. We would then run the model from this policy choice time point into the future, separately for each of the two health policies we want to compare. Then we would compare the outcomes, including the DALYs and the costs. And we would then calculate the difference in costs and the difference in DALYs between the two health policies. So if the new policy results in lower DALYs, which is a good thing, but also higher costs, then we can calculate the incremental cost effectiveness ratio, or ICER, as the difference in costs between the policies divided by the DALYs averted by the new policy. So this ICER can be compared against a predefined cost effectiveness threshold, which represents the added cost to the healthcare system to avert one further DALY. If the ICER is below the threshold, this suggests the new policy is cost effective. Now, individual-based models also have uses in descriptive epidemiology. So let's consider an example of calculating the life expectancy of a person living with HIV from age 30. So how would we go about estimating this? Life expectancy is often calculated by assuming that age-specific death rates at a given point in time hold for a person's lifetime. But in an HIV positive person, the risk of death can change dramatically over time. In a person who is not on treatment, either because they're not diagnosed or just not on treatment, the rate of death increases sharply as the CD4 count declines to very low levels. The rate of decline in CD4 count varies a lot between individuals. So if the person is tested for HIV and diagnosed and starts treatment, the risk of death declines substantially. In a person on treatment with an undetectable HIV viral load in their blood and a high CD4 count, the extent to which the risk of death is higher than if HIV had not been present is low. So let's consider how we might estimate life expectancy using an individual-based model. Let's consider a person who's infected with HIV at age 30. Recall that an individual-based model is largely defined by the list of variables or attributes for each individual and the expressions that determine how each variable value is updated in each time step. So just considering a simple model as an example for illustration, the list of variables or attributes for each individual might be the HIV viral load, their CD4 count, whether they're diagnosed or not, whether they're on antiretroviral treatment or not, whether they've died from AIDS, and whether they've died from a non-AIDS condition. So let's consider the expressions that determine how each variable value is updated in each time step. So the viral load at time t plus 1, the next time step, will depend, let's say, on the viral load at the current time step t, whether the person's on treatment, with an added element of random chance. The CD4 count in the next period depends on the viral load at the time t, the CD4 count, whether the person's on treatment, and an element of random chance. Whether the person's diagnosed in the next time period depends on whether they're currently already diagnosed in time t, and whether diagnosis occurs at this period. Whether the person's on treatment at time t plus 1 depends on whether they're on treatment at time t, on the rate of treatment interruption that occurs, the rate of treatment resumption that occurs in the people that have interrupted antiretroviral treatment, and again an element of random chance. Whether the person has died from AIDS at time t plus 1 when they were alive at time t depends on the viral load to some extent at time t, certainly the CD4 count at time t, whether they were on treatment, and an element of random chance. And lastly, whether they've died from a non-AIDS condition at time t plus 1, given our model variables, depends only on age and random chance. Now, by building an individual-based model with these variables and these transition rules, and running it for, say, 70 years for 1,000 simulated people, we get a picture of the various possible outcomes for the person by different ages. Now, we previously, actually about 10 years ago, built a model to do exactly this. And you can see here the results from the published model on the states that people might be in with various probabilities by the number of by their age subsequent to having been infected at age 30. Now this is more complex in reality than I've described here in this example because of a need to account for specific drugs and drug resistance, and there's also a slightly increased risk of non-AIDS death in people with HIV. This was taken into account in the cited paper, but what I've shown you here illustrates the approach of using an individual-based model. So how are individual-based models built and run? So these are obviously programmed on computers using various languages. Examples would be C++ or Python, but can also be done in some statistical packages such as R or SAS. And there's dedicated software, and I've listed some URLs for where those can be accessed. We've also listed here some examples of individual-based models for COVID-19 and for HIV. Here are a couple of articles that you might be interested in if you wanted to read into this further. So to sum up, we aim to provide an introduction to individual-based modelling in epidemiology and to inform policy, and we hope that this has provided this to you. We'd be happy to read any comments with suggestions for enhancements or clarifications of what we've presented. Thank you.